So it gives me great pleasure to introduce our next speaker today, who is Dr. Jen Walsh. And I'll tell you a little bit about her before she comes up to the stage. So Jen leads, is she via Zoom? Is she? Okay, all right then. So before we join her via Zoom, Jen leads the research and education teams at the Centre for Sleep Science at the University of Western Australia and the Sleep Physiology Research Team at the West Australian Sleep Disorders Institute. Her research focuses on investigating the causes of and treatments for sleep disorders, including obstructive sleep apnea and insomnia. Since 2016, her research has included investigating the use of medicinal cannabis for the treatment of sleep disorders. She is a board member of the Australasian Sleep Association, is a proud and active member of the Australian Sleep Health Foundation. Her presentation today is titled "The Use of Medicinal Cannabis for Sleep and Sleep Disorders and Related Australian Research." Please welcome Jen.
Thank you so much for having me. I'm sorry that I can't join you there in person. It looks like a fantastic turnout. And I importantly hope that everyone's had a good night's sleep after the gala dinner. And if you didn't, then I hope you've grabbed yourself a coffee in the morning tea break. So I will go straight into my presentation. Or actually, I first should mention some potential conflicts of interest. Our research team have received research funding from Xilira Therapeutics and Healthcare, Incannix Healthcare, but it should be noted I've received no personal funding from these companies. So this is an excerpt from an early medical report by William O'Shaughnessy. It was published in the Provincial Medical Journal in 1843. And in it, it describes a number of medical conditions in which cannabis was used. And I've highlighted a section down here. Larger doses, again, were shown by the historical statements to induce insensibility or to act as a powerful sedative. So this is one of the earliest published reports of the use of a cannabis product for inducing sedation or sleep. And I mean, we've heard a little bit over the last couple of days that sleep is in fact one of the primary reasons for which people seek cannabis to use medicinally. And John Skerritt yesterday from the TGA noted that insomnia and sleep disorder are actually the third and fourth most common indications for SAS applications in Australia. Not sure why insomnia is separated out from sleep disorder. It has its own category, and I suspect there's perhaps a little bit of overlap there. But yeah, I mean, we've heard very clearly there's a lot of evidence that sleep or sleep problems are generally the third most common reason that people seek to use cannabis medicinally. So in my talk today, I'm going to talk about the current clinical evidence for the use of different cannabinoids in the treatment of sleep disorders. And I'm going to focus on the clinical evidence rather than the pathophysiological rationale for their use, because I think if I was to go down that route, then we probably need a little bit longer than 20 minutes. So I'm going to start by talking about the effects of different cannabinoids on sleep architecture and sleep quality. Then I'm going to talk about their effect on these sleep disorders, so insomnia or difficulty sleeping, obstructive sleep apnea, restless leg syndrome, REM sleep behaviour disorder, and PTSD-related nightmare disorder. So firstly, looking at just the effects of cannabinoids on sleep itself, so sleep quality and quantity. These are some of the metrics that we use in the sleep area to quantify sleep quality and quantity. So sleep latency is the time taken to fall asleep. Non-REM 3 sleep is the stage of sleep that's a very deep sleep. And we know it's very restorative and has very important functions. And REM sleep, rapid eye movement sleep, is also very important. And this is the stage of sleep that's typically associated with dreaming. Our total sleep time, and then the wake time during our sleep period, or wake after sleep onset, we call WASO. So I think there have been a number of studies which have examined the effects of cannabinoids on these aspects of sleep. but the literature is really mixed, and part of the problem is that, you know, we've got quite varied sample sizes. People have been studied with, I guess, weak measurement tools, and also a lot of the studies have been based on chronic, regular or heavy cannabis users, or perhaps they've just studied people in a single night. So it's quite hard to come up with a broad summary. However, if I was to do that, this is how I would, I guess, summarise the evidence that we have to date. So in the short term, I think we can say that the evidence indicates that cannabinoids have a beneficial effect on sleep. But I think if we start looking into longer term or chronic use, perhaps it's not as beneficial, perhaps there's a tolerance. And then if we look at withdrawal, then I think that we can say that withdrawing from cannabinoids probably has quite negative impacts on sleep, particularly on sleep latency. However, remember, this data is derived largely from the literature which is based on chronic or heavy cannabinoid use. So how we can extrapolate that to use or in doses that is similar to medicinal use, I think we really need a little bit more evidence. So firstly, the first sleep disorder that I'm going to talk about is insomnia. So this is typically, I mean, I think most people understand what insomnia is, but our clinical definition is along the lines of difficulty with sleep initiation or maintenance, despite the opportunity to have good sleep, and there's subsequent impairment in daytime function. Now, in regards to the effects of cannabinoids on insomnia, there have been a number of retrospective or unblinded or open label studies or reports which have examined different cannabinoids on sleep quality, and they're typically assessed by self-report or questionnaire. I'm going to talk, what I've presented here are studies with more robust designs. So these are randomized, blinded, crossover trials where sleep was the primary outcome measure. And the population that was studied presented with insomnia or poor sleep rather than other health conditions and or no sleep problems whatsoever. So you can see that the earliest sort of most robust, so it was a randomized placebo-controlled study, was done in 1973 or published in 1973 in people with self-reported insomnia or sleep difficulty. And unfortunately, that outcome measure wasn't as robust as we would like. It was someone who visually observed patients whilst they were sleeping. So they weren't actually measuring their sleep in any scientific way. It was just through observation. But we can see that there was a decrease in that sleep latency, so the time taken to fall asleep, with different doses of a THC. And it didn't affect the amount of wake time that people spent after they fell asleep initially, or their total sleep time. So yeah, there was a beneficial improvement in the time taken to fall asleep. Similarly, there was a trial done in 1981, and this looked at CBD and in patients at different doses. And these were patients who had, again, a self-reported difficulty falling and staying asleep. The outcome measure was a self-reported scale. It was a self-reported scale of how well they think they slept. And there was a improvement in self-reported sleep duration. So again, remember, these are both self-reported outcomes. There was a subsequent trial looking at a synthetic THC for 2 weeks, and this used questionnaires, validated questionnaires for insomnia. So we've got a lead sleep evaluation questionnaire and insomnia severity index questionnaire. And with the synthetic THC at a dose up to 1 milligram, There was a decrease in the insomnia severity index, but there was no change in the other questionnaire. And finally, the same synthetic THC, this time at 4 weeks, or taken for 4 weeks. And at some point during the trial, because this was published only in abstract form, so there's not much information about it, the patients had a sleep study in a sleep laboratory. So this would be our sort of gold standard assessment of sleep. And this trial actually found that there was no improvement in total sleep time or sleep efficiency, so that is the amount of sleep people got across the night. And there was actually an increase in the amount of time that it took these people to fall asleep. And this was just statistically significant. And I think we would say that an increase in half an hour falling asleep is clinically significant as well. So it's interesting that this study found that people with chronic pain and insomnia, actually, when they took NAB alone for 4 weeks, although this was assessed over a single night, had an increase in the time taken to fall asleep. Perhaps this has something to do with the fact that these patients had pain, chronic pain, and perhaps we don't know what dose it was that they were taking either. So, but I think this goes to show that although the data from these earlier trials is quite promising, this one perhaps isn't so promising, that we really need more evidence. So recently our team at the Centre for Sleep Science conducted a trial with Xelira Therapeutics, examining the effect of a cannabinoid formulation on treating insomnia symptoms. And I should say that although Xelira sponsored the trial, they actually had no input into the trial design or the data analysis, so it was independently done by our team. The trial was a 2-week double-blind randomized placebo-controlled crossover trial, and the formulation included THC, a bit of cannabinol, and a bit of cannabidiol. And the product there was a placebo that was matched for color, taste, and odor. 24 participants were recruited, and they had chronic insomnia symptoms, and they had to have this insomnia severity index score greater than 10 to be eligible. 23 participants completed the trial, and we can see that this is their insomnia severity index, and this is the group mean relative to baseline when people were taking the active medication, which was called Zetia 101, but it's now available on the market as Zenivol, that there was a significant decrease in their insomnia severity. And this was also demonstrated relative to, the difference was also demonstrated relative to placebo. So this is quite a large treatment effect, and it's encouraging given that it was a short-term preliminary trial. Relative to placebo, the active medication also changed self-reported sleep quality, so the time taken to fall asleep decreased, the amount of time that people reported sleeping increased, as did their self-reported feelings of sleep quality and feeling refreshed on waking in the morning. And encouragingly, these results align with the actigraphy base. So actigraphy is a measure of sleep based on wearing a watch on your wrist. And so this is what we would consider a more objective measure of sleep. And their self-reported improvements in sleep align with the measurements that we obtained from actigraphy, that there was an increase in total sleep time and a decrease in the amount of time that people spent awake during the night. There was no change in the actigraphy-based measure of sleep latency. And finally, we also measured their sleeps in a sleep laboratory with polysomnography. So this is our gold standard measure of sleep over a single night. And there were no differences in any of the measures of sleep quality or quantity when people were taking the active medication versus placebo. Now, this is not entirely unexpected, because we do understand that there are limitations of putting people in a sleep laboratory on a single night to measure their sleep, particularly patients with insomnia who have trouble sleeping in unusual environments. However, we would like to see some of these sleep variables improve with this measure of sleep, of this gold standard measure of sleep. Interestingly, the proportion of REM sleep was reduced by 3.5% when people took the Xenivol medication versus placebo, although this just failed to meet statistical significance. Okay, moving now to obstructive sleep apnea. It's a sleep breathing disorder which is characterised by repeated episodes of partial or complete collapse of the upper airway due to potential effects on the respiratory stability and upper airway muscle activity. Cannabinoids have been considered as a therapeutic potential for treating obstructive sleep apnea. Now, a group in the US from the University of Illinois conducted some preclinical trials, and they had some very promising results. So nearly 10 years ago now, they conducted this proof of concept 3-week open label trial where it was a dose escalation where people took 2.5 milligrams of dronabinol for a week, and then they increased it to 5 and 10 milligrams for the second and third week if they were able to tolerate it. And they ended up with 15 patients who completed the trial. And you can see that in those 9 patients who were able to dose escalate up to 10 milligrams over the 3 weeks, that there was some variability. But in general, there was probably a decrease in the severity of their obstructive sleep apnea, which is the number of apnea and hypopnea events per hour. That's how we describe the severity of obstructive sleep apnea over that 3-week period. And in those patients who were able to dose escalate up to 5 milligrams, this is their results. And, sorry, let's go. It's a bit of a failure. I jumped right to the end then. Here we go. In those patients who were able to only tolerate 2.5 milligrams, there were 2 of them, and we can see their results here. So in general, despite the considerable intra and inter-individual variability across all of the participants, there was a significant decrease in the severity of their sleep apnea by 29% at week 3 relative to baseline. So with these sort of promising early results, the same group conducted a 6-week randomized parallel group placebo-controlled trial where patients were randomized to either a placebo group or they were randomized to take 2.5 milligrams of dronabinol or 10 milligrams of dronabinol. And there were 56 patients completed the trial, and we can see the outcomes here. Now, there were differences in the baseline severity of their obstructive sleep apnea across the groups, unfortunately. So it meant that the data, unfortunately, is harder, a bit more difficult to interpret. But in the group that took the 10 milligrams of dronabinol relative to baseline, there was only a 16% decrease in the severity of obstructive sleep apnea. But when the scores were adjusted for baseline OSA severity, as well as age and gender, there was it was a 12.9 event per hour, nearly 13 event per hour decrease in the severity of their obstructive sleep apnea, which is quite large. But yeah, because of these baseline differences, it makes it quite difficult to be super confident about the outcomes. But recently, our group have completed data collection as part of a multi-centre trial with the Alfred Hospital and Incanix Healthcare, investigating the effects of a combination of dronabinol and acetazolamide on OSA severity. And this was it's a 1-week randomized placebo-controlled. It was a dose-finding trial, so there was a placebo arm as well as low, medium, and high dose arms. 10 participants have completed this proof of concept study, and I can only share the preliminary data at this point as the data analysis is still underway. But you can see here that when patients were taking placebo, or relative to taking placebo or baseline, there was a decrease in their OSA severity when they were taking a mean of those different doses of dronabinol plus acetazolamide. So in general, on average, there was a 44% decrease in the severity of their sleep apnea versus baseline. So although I think we probably agree that we need more evidence in a larger population to support the routine use of cannabinoids for treating obstructive sleep apnea, these data are quite exciting. And I think one of the really exciting things about using cannabinoid or any pharmacotherapy for treating obstructive sleep apnea is that if we have some more research, some more evidence, we can actually work out which of the causes for obstructive sleep apnea these treatments are influencing, and therefore we can identify those patients who are most likely to benefit from them. There's also been some suggestions that cannabis might be beneficial for treating patients with restless leg syndrome. So for those people not familiar with restless leg syndrome, it's a sensorimotor disorder which is characterized by an unpleasant urge to move the legs. And for people who experience it, particularly in its moderate and severe forms, it can really significantly affect sleep quality and quality of life. There have been 2 case series published, a total of 18 patients, and these patients were from the same clinic. So it was the same author that published both case reports. And the patients took cannabis of their own accord and had reported it to their physician. And they reported basically that the cannabis had improved their restless legs symptoms. Now, what I've got on this slide is the data from the second case series of 12 patients. And you can see that you probably don't know what this score means, but this is the severity of their restless legs disorder. And they're moderate to, but most of them are severe or very severe. And you can see that the medications that they had taken in the past and the medications that they were currently on, including things such as pregabalin and gabapentin, lots of opioids and dopamine agonists. And despite taking all these medications, they still had very severe symptoms of restless legs. In the first case series, there was 100% resolution of the symptoms in patients who self-reported using cannabis of their own accord. And in this case series, we can see that there's total remission in 66% of the patients. Another 3 patients had a 60, 80 or 90% improvement in their symptoms. And there was only 1 patient of the 12 who reported no symptom improvement. And importantly, all the patients also reported that the side effects were less when taking the cannabis than when taking their other medications to treat their restless leg syndrome. Now, I'm a scientist, and so I'm aware that self-report of cannabis use is a huge risk of bias. So we do need some randomized controlled trials, and we also should have an objective or use an objective measure of the restless legs disorder. But I think that this data is really exciting, and I'd really like to see some randomized controlled trials in this area. Now, rapid eye movement sleep behavior disorder, or REM sleep behavior disorder, it's a parasomnia which is characterized by dream enactment. So typically when we are in REM sleep and when we're dreaming, our muscles are completely inactive. And that's a protective mechanism. In people with REM sleep behavior disorder, their muscles, they've lost this protective muscle atonia, and they can actually act out their dreams. And because the dreams of people with REM sleep behavior disorder are often violent in nature, the individual often experiences injury to themselves or to a bed partner. And unfortunately, with REM sleep behavior disorder, it also often precedes the development of neurodegenerative disorders such as Parkinson's disease. The treatments for REM behaviour disorder currently are quite limited, and they have limited efficacy and significant adverse effects. So we really do need some alternative therapies. In 2014, a Brazilian group looked at or published a case report of patients with REM behaviour disorder and Parkinson's disease, and it was self-reported symptoms of REM behaviour disorder, and patients were taking 75 and up to 300 milligrams nightly of CBD, and they had a near complete resolution of symptoms in 4 patients. So based on this, there was a 12-week randomised control trial conducted with 300 grams of CBD nightly versus placebo. And it was conducted in 36 patients with REM behaviour disorder and Parkinson's disease. And the outcome measure was a REM behaviour disorder frequency as recorded in a diary by the bed partner. Now, we can see the results here. And there was the frequency of REM or weekly REM behaviour disorder or episodes was greater in the placebo group. So this is those in blue, across the study at different time points here, than in the group that took the CBD. But you can see that the frequency decreased across the study in both groups, which is potentially due to a Hawthorne effect, where partners' observations have changed just purely because their bed partner is in a trial. So there was no significant interaction effect. And the authors concluded that maybe the CBD isn't efficacious in reducing the REM behaviour disorder symptoms. But I do wonder whether this just bed partner diary is really the best way to measure REM behaviour disorder symptoms. I think we can come up with some more objective measures. So I'm not sure that this trial really allows us to draw a line under this as a solid conclusion. And finally, I want to just touch on nightmare disorder. So recurring nightmares are one of the most distressing symptoms in people with PTSD, and they can be difficult to treat. There have been a couple of retrospective case series which have been published. So one included 47 patients with a 2-year history of treatment-resistant nightmare disorder. So there was 47 patients, and they were prescribed nabilone for 2 weeks, up to 4 milligrams. And in 72% of those patients, there was a significant reduction in their nightmare frequency. 28% of the patients discontinued use of the nabilone quite early on in the treatment period due to adverse effects. And there's also been a case report of, there were 90 prison inmates who reported frequent nightmares, and they had nabilone again, so synthetic THC, for, on average, it was about 11 weeks, and the dose was up to 6 milligrams per night. And there was a self-reported decrease in nightmare frequency from an average of 5.2 nights per week down to less than 1 night per week. Interestingly, there was also an increase in their total sleep time by over 2 hours, which was quite significant. And there's also been a blinded randomized placebo-controlled study involving 10 patients or 10 participants, and they took nabilone nightly up to 3 milligrams for 7 weeks. 7 of those patients reported a significant improvement in their nightmare symptoms according to a validated scale. So that's when they were taking nabilone, versus a 20% of these participants reported an improvement when they were taking placebo. So again, I think these results are promising, and they certainly warrant further research in larger cohorts. So in summary, I would say that at this point, conclusive evidence to support cannabinoids as a routine therapy for sleep disorders is really not quite available. So when I say routine therapy, I'm really talking first-line therapy. However, evidence from randomized control trials suggest that cannabinoids may be beneficial for treating patients with insomnia symptoms, patients with obstructive sleep apnea and PTSD-related nightmare disorder. And in addition, we do have some really promising case report data that cannabinoids may be beneficial for restless sleep syndrome and REM sleep behaviour disorder. So where do we go from here? We need more randomised placebo-controlled trials of cannabinoids for each of these specific sleep disorders, and we really need to use some high-quality measures of sleep and the symptoms of these sleep disorders. And we need to include a suitable placebo. We need to consider what happens with long-term use, because a lot of these trials are short-term, and we also don't look at what happens when people withdraw from cannabinoid use. The product that is used, it needs to have an innocuous route of delivery. So some of what I've shown you is from inhaled cannabinoids or cannabis, and long-term, that's probably not an option for most people. And the product should have quantifiable dosing. We need to be able to quantify how much people are having, and there needs to be the capacity to have graduated dosing. And I think that this is one of the great benefits of cannabinoids, is that we do have the capacity to give in graduated, starting with small doses and increasing slowly. And it would be great to elucidate some of the biological and the physiological mechanisms, how cannabinoids are acting in some of these conditions. And I think we're almost able to do that in a number of them. And I guess to throw another log on the fire of changing the driving regulations, I think pending outcomes of research investigating impairment in driving, we need to modify our driving regulations, particularly in all of these trials that I've talked about. People are taking cannabinoid at nighttime, and typically it's in a very low dose. So I think we really need to look at changing our driving regulations. And finally, I just want to put up a list of everyone who's worked on the research that we have done at the Centre for Sleep Science, because this is certainly not a one-man show. We need lots of people to do this research. So thank you very much. I'll leave it there.